Continuing with your previous year NEET question. So another 2024 question on cardiology. It's a dyslipidemia question. A patient with multiple tendon xanthomas has serum cholesterol of 404 milligrams per deciliter. His LDL is 230 milligrams per deciliter. What is the most likely defect? So you can find the answer from many of the clues here. Tendon xanthomas. You would have heard about the classification of familial hyperlipidemias. So lipids are of various types: VLDL, LDL, IDL, HDL, and triglycerides. So if it is high, if any of these variant is high, it is called as familial hyperlipidemias. In that, based on the clinical clue, based on the genes, based on the type of lipid which is high, it is of 5 different types. Fredrickson's classification. So we have tendon xanthomas is very, very typical of familial hypercholesterolemia. So this again has been asked multiple times from different subjects. If tendon xanthoma is present, the diagnosis is invariably familial hypercholesterolemia. And the mutation for familial hypercholesterolemia is LDL receptor. There are many variations, or there are many mutations causing it. The most common mutation is LDL receptor or the downstream signaling molecules of LDL receptor. So one best answer is LDL receptor. It's like an one-liner. Suppose if this tendon xanthoma is not given, they are only giving the value of LDL. Remember, I told you 5 different types of hyperlipidemia. In that, familial hypercholesterolemia is type 2, and in that LDL is high. Okay, I'll show you the chart shortly. So if the word tendon xanthoma is there, the diagnosis is familial hypercholesterolemia. If the word LDL is high is there, the diagnosis is familial hypercholesterolemia. It is of 2 types, heterozygous and homozygous. We are not going into the details. So considering this as a one-liner, the answer is LDL receptor defect. We'll see the other dyslipidemias. So this classification is called Fredrickson's classification. Fredrickson's classification. So we have 1, 2, 3, 4, 5. 2 is of 2 types, 2A and 2B. So we'll go one by one. 1 is called as hypertriglyceridemia. 2 is familial hypercholesterolemia. 2B is combined hyperlipidemia. 3 is called as apolipoproteinemia or remnant hyperlipidemia. 4 is again hypertriglyceridemia. 5 is again hypertriglyceridemia. Remember, 1 they are given here, it as dietary hypertriglyceridemia. The dietary triglyceride is actually chylomicrons. So type 1 is also called hyperchylomicronemia. Hyperchylomicronemia. Remember, chylomicrons are triglycerides from the diet. So what is the mutation here is lipoprotein lipase. So type 1, elevated chylomicrons, lipoprotein lipase. 2A is the one which we have discussed just now, the familial hypercholesterolemia. What is elevated? LDL is elevated. What is the mutation? LDL receptor. Okay. 2B is combined hyperlipidemia. LDL, VLDL, everything is elevated. It's not very important for MCQs. Type 3 is also called as apo-beta lipoproteinemia. Okay. It is due to mutation in apolipoprotein. Here again, IDL is very high. Okay. Type 4 and type 5 are again hypertriglyceridemias, and the mutation is different. So for your exam purposes, type 1 is important because it is hyperchylomicronemia. The mutation is lipoprotein lipase. Type 2A is important because it is the classical familial hypercholesterolemia. The defect is in LDL receptor. Type 3, familial hyperlipoproteinemia type 3 is important. Here there is elevated IDL. Type 4 and type 5 there will be elevated triglycerides. Now since image based questions are there, I'll show images of few terms. I just told in familial hypercholesterolemia or type 2A familial hyperlipidemia, this is what occurs. In Achilles tendon, we commonly get fat deposit. It is called as tendon xanthoma. Tendon xanthoma is also the clinical finding in another disease called as primary biliary cirrhosis. So in these two diseases, we get tendon xanthomas. So tendon xanthoma is due to increased LDL, if you remember, right? You can correlate with the clues. This is elbow joint. You can see multiple small eruptions. This is called as eruptive xanthoma. So where does eruptive xanthoma occurs? Eruptive xanthoma occurs in conditions where triglyceride or chylomicron is high. Triglyceride is high in type 4 and type 5 hyperlipidemia. Chylomicron is high in type 1 hyperlipidemia. Remember, chylomicron is nothing but dietary triglyceride. Chylomicron is dietary triglyceride. Here you can see eruption is in the palm. So this is palmar xanthoma. Palmar xanthoma, this is also a very important one-liner. This is a typical feature of type 3 hyperlipidemia or familial A-beta lipoproteinemia. Okay. This is also a summary slide. Type 1 is familial hyperchylomicronemia. Chylomicrons are high. It's due to lipoprotein lipase. Type 2A is familial hypercholesterolemia. LDL is high. Here we get tendon xanthomas. So type 4 and type 5 triglycerides are high. So it is familial hyperlipidemia, familial mixed hyperlipidemia. Type 3 is familial dysbeta lipoproteinemia. Here IDL is high, intermediate density lipoprotein is high. Clinical clue, in familial hyperchylomicronemia there will be eruptive xanthoma. Type 4, type 5 hyperlipidemia also there will be eruptive xanthoma. So any condition where triglyceride is high, there will be eruptive xanthoma. Our famous familial hypercholesterolemia, there will be tendon xanthoma. In type 3 or familial dysbeta lipoproteinemia, there will be palmar xanthoma. So let this be a revision slide. Suppose if image they give this one, this is called as xanthelasma. This is not very typical of a particular type. This occurs commonly in hyperlipidemia, any type. The composition varies. This actually has bile esters. Right, so so we'll discuss the other options. So from this question, tendon xanthoma, very high LDL, it is familial hypercholesterolemia type 2A, LDL receptor defect. Now lipoprotein lipase, as we discussed, it is type 1 hyperlipidemia or familial hyperchylomicronemia. Here there will be eruptive xanthoma. Defective ApoB100. So A-beta lipoproteinemia, right? Familial dysbeta lipoproteinemia or A-beta lipoproteinemia. This is rare one. Here IDL is high. Here we get palmar xanthoma. So one revision slide can give you many questions. PCSK9 gain of function mutation. Since this is a one-liner, you can leave off this option, but PCSK9 being very important, I'll just tell you a brief description about PCSK9. Don't worry about the full form. PCSK9 is a protein which degrades LDL receptors in the liver. What is the function of LDL? It collects the LDL from the blood and deposits it in the liver. So when PCSK9 activity is more, or when there is gain of function mutation of PCSK9, or when PCSK9 is increased, what happens? LDL receptors reduce in number. LDL receptors reduce in number. So excess LDL cannot enter the liver from the blood. So excess LDL stays in blood and it increases blood LDL levels. So PCSK9 gain of function mutation or increased PCSK9 activity is one reason for increased LDL. I told you there are many mutations causing familial hypercholesterolemia. So PCSK9 also could be one of them, but it is not very common. Now why this is very important? Because of therapeutic implications. We have a category of drugs called as PCSK9 inhibitors. So they are drugs when given, they reduce degradation of LDL receptors. So LDL receptors increase. So it takes over more LDL from the peripheral blood and deposits it in liver. So PCSK9 degrades LDL receptor in liver. PCSK9 inhibitors prevent the degradation and increase LDL receptors. Hence they reduce LDL in the blood. So example for PCSK9 inhibitors are alirocumab, evolocumab. These are injections. These are injections given once every 3 months, like that. So remember, there are some injections for hyperlipidemia. The next variant of this PCSK9 inhibitor is siRNA, small inhibiting RNA of the same PCSK9. So alirocumab, evolocumab are drugs which act on the PCSK9 to inhibit it, whereas siRNA, there are some RNAs which inhibit PCSK9. Example is inclisiran. This is also very important. This is also an injection given once every 6 months. It is called as lipid vaccine. So like we give a vaccine to prevent infections, to prevent dyslipidemia, to treat dyslipidemia, we are giving this injection once every 6 months. This is the latest update. They are very costly drugs, but worthy for your exams. In this slide also I had presented to you. See, the type of drug given in dyslipidemia depends on the type of lipid which is elevated, because if TGL is high, we give fibrates, fenofibrate, etc. If LDL or VLDL is high, we give statins, atorvastatin, rosuvastatin, pitavastatin, etc. The next step, when LDL is high, the next step which we give is ezetimibe. If still not controlled, the next step what we give is PCSK9 inhibitor. So some say in familiar hypercholesterolemia, you need not wait for these two steps. You can directly go to PCSK9 inhibitor or inclisiran, which is the final and effective step. We have other drugs, niacin. One question was asked about niacin in 2024 also. Okay. So this is a very important question. So we discussed many important things about it.